As Captain Gallardo stated, this is a presentation about Signs of Suicide, which is a school-based universal suicide prevention program that's developed by Screening for Mental Health, a nonprofit in Boston, Massachusetts that may be known to you as the creators of National Alcohol Screening Day and National Depression Screening Day. Next slide, Naomi. Much of the evaluation work for SOS has been conducted by the UConn Health Center independently, with funding through the Center for Mental Health Services, private funding from the Patterson Trust, and also from the Department of Defense. As was noted, this has been featured as a program by many Garrett Lee Smith Act grantees. One of them was the state of Connecticut, and we collaborated on that as well. Next slide. Now, the goals of SOS as a universal suicide prevention program is to reduce suicidal behavior primarily among adolescents in a high school setting. Typically, it is introduced to younger high school students in the 9th and 10th grades, largely because of when health is taught at the high school level in the United States. The goal is to help teens understand the connection between suicide and undiagnosed and untreated mental illness, principally depression. In doing so, it attempts to destigmatize suicide, depicting it more as the result of illness than as a lack of character or a character defect, or just a normal functioning individual being overwhelmed by events. And then once that message is conveyed, the goal is then to mobilize peers to act. And ACT is an acronym for Acknowledge, Care, and Tell. And targeting peers, from my perspective as a sociologist, is very appropriate given the developmental transitions that are occurring during this age, where peers become really the most prominent sphere of social activity for youth. Helping peers to recognize friends that are in trouble is then a critical component of this program. Next slide. The program really consists of a 1 to 2 period presentation and discussion that's administered by either teachers or school counselors. We have worked with schools that have gone both ways on that in terms of the personnel that are used to present the program, and both have been equally effective in our view. The main teaching tool is a video, approximately 20 minutes long, called Friends for Life. And it consists of roughly equal components of professionals talking about the relationship between depression and suicidal behavior, and vignettes where teens are confronted with common situations, common stressors that they face, and the right and wrong ways to respond to those when a friend is presenting with distress. Also, it includes a discussion guide that reinforces the message of the program. And finally, and what I consider to be a very critical component, a screening instrument that is completed by all students and self-scored. What has been used in the program for the past several years is the Brief Screen for Adolescent Depression, or the BSAD. That has some very good psychometric data on it and is fairly easy for students to complete and score themselves. Next slide. We have done a number of different outcome evaluations with SOS. What I'll talk most about today is the results that have been presented in 2 publications over the last 5 or 6 years that involved more than 4,000 students in schools in Connecticut, Georgia, and Massachusetts. This design used in these studies were randomized experiments where half of the classes in each school did SOS in the fall. The other half were essentially waitlist controls and did SOS in the spring. And then roughly 3 months following the exposure to the program among the treatment or intervention group, all students completed a questionnaire that indicated their knowledge and attitudes about suicide and depression and their recent suicidal behavior. This was a post-test only data collection design. Now, we have since replicated these results with designs that included both a pre-test and a post-test. That is, we got baseline data before anyone was exposed to the program, and then again at the follow-up. And these were anonymous questionnaires that are completed in a group setting during class time administered by trained professional interviewers. Next slide. As I said, there are three sets of measures that we are primarily focusing on in terms of outcomes. The first set is indicators of knowledge about suicide and depression and attitudes regarding suicide and depression. While most of the measures that we used in this study were taken from existing instruments with known psychometric qualities, these, by their very nature, had to be customized for the particular program, although we did base these measures on those that have been prominently and widely used in other suicide prevention research. In terms of help seeking, we took 3 items from the National Comorbidity Survey about the extent to which youth had talked to other adults or professionals in the past 3 months about problems that they were having. And then finally, we used 2 items, one on suicidal ideation or thoughts about suicide, and then the self-reported suicide attempts over the past 3 months from the youth risk behavior surveys that many of the schools across the country have participated in through the CDC over the past 10 to 15 years. Next slide. In terms of results, we saw that exposure to the SOS program created better knowledge or improved knowledge and more favorable attitudes about depression and suicide relative to untreated controls. You'll see the red bars here on this graph indicate that both effects were statistically significant. They were modest in magnitude. We would characterize this as roughly a quarter of a standard deviation, which is substantively and, in this case, statistically significant. If we go to the next slide, we also see, and this is really the critical finding that we were able to report, is that while there was only a slight decrease in suicidal ideation that was not statistically significant, there was a substantial decrease in self-reported suicide attempts. Controls reported a rate of about 5% over the past 3 months, while those who received the SOS program reported a 3% rate, or 3% of them reported an attempt in the past 3 months. Now, this pattern of results is actually very consistent with a logic model for SOS. SOS is not a depression prevention program, and therefore it wouldn't really be expected to curtail thinking about suicide. Its focus is on preventing the actual behavior, and so seeing this pattern of results is, I think, encouraging given the program's logic model. And then finally, if we go to the next slide, we also looked at the effect of SOS on help seeking. Now, it is part of the logic model to anticipate that this would be stimulated among those exposed to the program. And as you can see in this graph, that there's actually lower levels, although none of these are statistically significant, lower levels of help-seeking behavior on the part of those exposed to the program. We've actually thought a lot and been doing some subsequent work on this. This may come up in the question and answer period, but our thinking at this point is that there may be methodological issues why it is difficult for us to see some help-seeking effects in studies of this type. Next slide. So in summary, SOS is the first program, particularly universal suicide prevention program, to be shown to curtail suicide attempts in a randomized experimental study. It is well received by schools. We're going to hear a presentation in a moment about those aspects of the program, but we've always found that schools found it to be easy to use. It's very flexible. Its modular design fits into existing health curricula very well, and the kids seem to like it. In addition, or I should say as a result of this research, it was added to SAMHSA's National Registry of Evidence-Based Programs and Practices. And currently it is used in well over 1,000 schools. I think the last time I spoke to Screening for Mental Health, their estimate was about 1,500 schools in the United States are currently using the program.